Hello everybody, today we're going to be doing a spinal and epidural. We're going to go ahead and show the notes, boss. Thank you. Alright, so we're going to go ahead and first do a quick assessment on the patient. We want to make sure we get any kind of allergies, any kind of anticoagulation and antiplatelets. Do they have any bleeding issues, or do they have any liver disease? Any kind of inappropriate platelet counts. We want a platelet count above 100,000. Any kind of fever, any kind of spine surgeries. Have they had any kind of scoliosis, any kind of fevers? So any neurological deficits, a baseline. This is a healthy 30-year-old patient, gravida 1, P0. She doesn't have any allergies. So we want to make this as quick of a procedure as we can for her, and so that way we discuss risk versus benefits. That includes any kind of risk for bleeding, nerve infection, nerve injury, nerve infection, posterior puncture headache. They might get a high spinal, they might get LAST. Some of the benefits include pain control, adequate pain control. Alternatives include general anesthesia, the use of like fentanyl and nitrous oxide to aid her, but she's consented, we've obtained consent, and so we're gonna go ahead and proceed. At this point, we wanna make sure that we have the proper positioning. We wanna make sure that she's in the, I'm gonna have my assistant helping me arch her back. She's gonna have her legs up on a stool, and she's gonna kind of bend over and opening those intervertebral spaces. So once we do that, we have all of our supplies. That includes PPE, masks, syringes, local anesthetics, all the things that we're gonna need here. And so once we open our kit, we would open up our kit. This part would be a clean procedure. And so to first figure out where we're gonna do it is we're gonna get the intercrystal line. This is at the top of the iliac crest around L4, which is about 2 vertebral spaces away from the conus medullaris. And this is kind of where the quad equina lies, so there's a lower risk of puncturing the actual cord. So once we mark it, once with a marker or a nail, now we can go ahead and clean. So we're gonna go ahead and clean. CHG is just a vigorous motion. So you just wanna let that dry appropriately. And then we would get the drape from our kit, and we would go ahead and place it sterilely where we want it, right over that L4 space. Okay, great. So once we do that, we want to go ahead and anesthetize the skin. We want to get 1% lidocaine, about 3 cc's. So we would draw that, we would lubricate. So we get our local anesthetic. And then we would also want to lubricate our syringe, our LOR, our loss of resistance syringe. But first, we're going to anesthetize the skin. We're going to go ahead and inject about 1 cc in the subcutaneous tissue, and advance the needle all the way in, and then inject as we're coming out. Great, so once we anesthetize the skin, now we can use our TUI needle. Our TUI needle is gonna go in through the different layers, starting with the skin, followed by the subcutaneous tissue, then followed by the supraspinous, interspinous, and lastly ligament of flavum. But we're gonna anchor on the interspinous. We're gonna take note of how deep we're in with our needle. Here we're about 2 centimeters, 3 centimeters, 4 centimeters, and then we start to get coarse feeling knowing we're in the interspinous. At this point, we would attach our loss of resistance syringe. So once we attach our loss of resistance syringe, it's gonna have about 3 cc's of NS, which is what we're gonna use to hydrodissect. So we wanna go ahead and attach. We're gonna slowly advance as we're feeling for loss of resistance. So once we feel loss of resistance, we're gonna hydrodissect. Great. We're in the epidural space. Remove our LOR syringe. We're gonna go ahead and grab our catheter, making sure that we take note of how deep we're in. We are about 5 centimeters deep with our needle, and so we just wanna go ahead and thread, count the centimeters. So once we're at 5 centimeters, we're at the end of the needle, and so we wanna thread an additional 5 centimeters. So at this point, we're gonna be at a total of about 10 centimeters total. And so at this point, we wanna go ahead and withdraw our needle while we're kind of slightly pushing in our catheter so we're not dislodging it further. So, so we wanna go ahead and take this out. And we wanna go ahead and secure it with Tegaderm. And we want to make 2 loops, making sure that we secure it in place. And we're gonna put that away. So once we do that, we've secured the catheter, we're gonna give our test dose. All right, so we're just gonna put in our catheter, our alligator clip here. We're gonna give our test dose. We're gonna give 3 cc's, 15 mics of 1 to 200 epinephrine, and 45 milligrams of 1.5 lidocaine. So we're gonna go ahead and do that now. So we're gonna go ahead and give our dose, looking at the monitor, making sure that we don't get any increase in heart rate, we don't get any kind of ringing in the ears, any kind of metallic taste. We're checking to see if it's intravascular or intrathecal. If they were intrathecal, they would get a very dense block, and that indicates that we're in the subarachnoid space, versus if it's intravascular, we would get like all the signs I just mentioned. So once it's secured, we're gonna go ahead and and we've confirmed it's in the appropriate placement. We wanna give 0.25% of bupivacaine, 8 cc's total, with a total of 100 mics of Fent, or 10 mLs. And that's gonna be 2.2 mLs over 2 to 5 minutes. That's to prevent like a very quick onset hemodynamic instability. So we've given our dose, and now we're gonna monitor vital signs, Q 5 minutes for 15 minutes, and we're gonna chart the sterile procedure. We went in a medial insertion, technique, placement. We're gonna document the measurements, how deep the catheter is, the positioning, and the drugs with the lot numbers that we used. Great. So now we're gonna go ahead and remove the catheter, and we're gonna pretend to do spinal. So we would have done the same thing. We would have get the medical history, making sure that we don't have any kind of aortic stenosis, making sure that we don't have any kind of obvious contraindications to this procedure. But we would anesthetize the skin with local anesthetic. Like I said, 1%, 1 cc in the skin, 2 cc's coming out. Great. So it's really important to have an introducer needle for these kinds of procedures, because the needle is so flimsy. But once we have our site that we know that we're gonna go into, we're gonna go ahead and advance the introducer needle with using the Bramage technique. And we're gonna go ahead and insert it, and this will probably hit the deepest it'll go is the interspinous ligament. So we wanna bury that, and we wanna go ahead and advance our spinal needle. This is a pencil point needle. We're gonna go in, we're gonna keep the stylet in, and we're gonna be feeling for a pop. Once we feel a pop, we're able to withdraw the stylet. So at this point, I'm advancing really slow, Bramage technique, really slow, really slow, really slow here. And then we feel a pop, distinct pop. We take out the stylet, holding the needle, and we wanna go ahead and we start seeing CSF flow, and that confirms that we are in the subdural space. Great. So then we want the subarachnoid space. And so we want to go ahead and give our dose. This is going to be 0.75 bupivacaine, a total of 1.4 mLs, total of 10.5 milligrams, and 10 mics of fentanyl, depending on how bad the pain is for the patient. And so it's really important that once we're giving the dose, we want to aspirate, making sure that we're getting CSF, and we want to inject some of the medication, turn 90 degrees, aspirate, making sure we're getting some medication, some CSF, inject the rest, and then aspirate. You just want to do it 4 times, making sure at every quadrant you're getting some degree of CSF return. And then once we finish that, we are good. We've given all our dose. This is a hyperbaric solution. We want to make sure that we lay the patient down. We want to give so they can spread appropriately. We also want to get our vital signs every 5 minutes. We're gonna go ahead and remove the needle. We're gonna make sure we get our vital signs every 5 minutes for 15 minutes. Again, documenting all the charting for the procedure, and that should pretty much be it. Thank you very much.